Robinson here today to talk with us about um, basically strategies for improving office effectiveness for taking care of asthma. He's with the Children's Specialty Services at UVM Medical Center and is the Vice Chair of Quality Improvement and Pop Health for the Vermont Children's Hospital. Um, I have heard Dr. Robinson speak on several occasions. He is articulate and thorough and has lots of good insight. We're going to try to maybe mute some folks. Tanya, can you go to the CME slide if we could do that? If you attend this in person, you can get CME credit for this. There is the QR code. If you have your phone out right now, you can take a picture of that and go to the link and get credit. So I think, without further ado, we're going to be convening. The collaborative practices are going to be convening at 1 o'clock for a half an hour additional debrief. So those of you that are here, I'll say for CME activity or academic interest, you can sign off, but we'll ask the participants to just hang on the call and we'll have some discussions about the collaborative data abstraction and other parts about the collaborative. So Keith, we're going to leave over to your screen to share. Thanks for being here.
Great. Can everybody see my screen?
Very good. Yep.
Okay, yes. Perfect. All right. Well, I want to thank everybody for joining us today. And I know it's been a long year over the last, pandemic, and then for us in the UVM Health Network, the cyber attack and everything. So we're going to talk today about some office systems relative to improving asthma care. But first, I think it's super important, as always, to talk about wellness. There's a lot of you that I know on the call and a lot that I don't know, but with everything that we've been through as a healthcare system over the last year and, continue to face, I just hope everybody's taken some time to enjoy Vermont in all its winter beauty. And I hope you and your families and your care teams are all doing well from the bottom of my heart. So be well. The chat box. I want to take the opportunity right now, if we can, to chat in some answers to this question here. So I'd love to be able to get some of your insight in terms of what work you've been working on relative to asthma or COPD, QI, and then some lessons about what's working, what hasn't worked when you're trying to improve care. So you can shout that stuff into the chat box. I've got that up on another screen. I'll continue to monitor that as we chat, because I just want to make sure that this is as valuable for everybody as possible. So certainly let me know what you guys have been working on. The thing that I want to make sure that we also is a point of framing. I guess I need to disclose that I'm a Yankees fan first and foremost. The second thing is sometimes in quality improvement, we try to do too much. We try to hit what I will refer to as the 5-run home run. Now, if you know anything about baseball, if you hit a grand slam, that's only 4 runs. And so when we say try to hit a 5-run home run, that, again, going back to, you can only have one person on first. In this case, it's Dr. First. You can only have one person on second. In this case, it's Derek Jeter. In this case, third base could be occupied by Dr. Levine, and we want to definitely shout out to his awesome team about managing the pandemic in the last year. So the point here is we can only do so much, right? So we try in QI not to not to overreach, right? We try to hit our goals, but not overreach and try to do too much, because that can cause a lot of burnout and fatigue. And in the context of what we're all facing right now, we need to be very mindful about that. So our goal today is to be succinct, and we're going to talk about some methods to improve office systems and achieve goals to improve care of patients with asthma. Our objectives today are, we're going to talk about the OneCare objectives relative to asthma and COPD in the Learning Collaborative. We're also going to identify some fundamental improvement science tools so that you can have some take-home lessons. If you already know this, I apologize for going over it. but hopefully there'll be a couple of good kernels for you to learn and take home back to your practices. The other part that we're going to do is I'm going to go at the end to some practical examples in the literature to improve asthma care for your patients in your practice. And so, again, a huge Yankees fan, Yankees pictures on the wall behind me. I was also a philosophy minor in college, and so my favorite philosopher was Yogi Berra. So he says, if you don't know where you're going, you might wind up someplace else. This is, again, a way of framing what we're about to talk about, which is quality improvement. And so in quality improvement, we typically will use the Institute for Healthcare Improvement model for improvement. And very clearly, we step down from the first question there, which is, what are we trying to accomplish, right? So that's having an interprofessional team that's really understanding your goals, what system you're trying to work on, and what needs to be done in order to improve it. The second thing is you want to know how anything you change will result in an improvement. A lot of times you guys are all smart. Like, we're in healthcare, we're innovative, we're compassionate, we're motivated, and it leads to a lot of good changes, but we are still data driven, and we want to know that what we change, what we do, will result in improvement. So you have to have a data system strategy to answer that question. And our experimental model in quality improvement is the PDSA cycle, or the Plan, Do, Study, Act cycle. And so that's what we use to test changes to make sure that we're on the right path, and that any of these planned experiments that we talk about and do, that they actually circle back and achieve our aim. So that's the framework with which we're going to proceed. Now, going back to the aims, when we talk about aims, there are two major types of aims. There's a global aim, and then there's a smart aim. We're going to first talk about the global aim. Now, global aim is something that it's a general view of what we're trying to do. So it's the general goal of our project. And so for us today, we're going to talk about improving care of patients with asthma in my practice. So generally speaking, sounds like a good global aim. That's great, but we need to be a little bit more specific about what we're trying to accomplish. And so to that point, we're going to have something that's SMART. Okay, so it's going to be specific, measurable, actionable, relevant, and time-bound. So our SMART aim, for an example, could be something like increasing asthma control assessment for asthma-related visits or well child checks using an asthma SMART form, and we're going to talk more about this later, from 68 to 90% by July 2021. So in that last statement, that in the SMART aim there, we're very specific about what we're doing. We're going to increase asthma control assessment at certain type of visits using a specific tool, and we're going from our current performance, so we know our baseline performance, and we know our future target performance, and importantly, we have a deadline. This is important to help your team get a hold of what you're actually trying to accomplish. And I think the other part of this is it actually holds us to some kind of deadlines, which is not to be punitive, but it's meant to just kind of keep us on track, because Lord knows there's way too much for us to do in our daily work to get everything done. So we can always get pulled in different directions and get distracted by different things. But these SMART aims help us, keep us on track and moving in a good direction. So it's really important right up front that we use global aims and SMART aims. Now, what I want to do in the next slide is talk about how to measure these things. So in healthcare, there are a ton of processes going on every single day. Some of them are connected, some of them not. Some of them work in one data system, some of them work in another, and so there's a lot of challenges. When we start talking about measuring quality, we talk about it in a couple of different ways. First and foremost, relevant to clinicians, we talk about process measures. These are the things that we control on a daily basis. This is, giving somebody an asthma control test in the visit, having them fill it out, and getting that done. This is me writing a prescription for an inhaled corticosteroid and sending it to the pharmacy. This is me providing asthma education to a family during the visit. Those are the things that I can directly control. These are also things that I think are going to directly lead to an improved health outcome. So the end result of that system are outcome measures. So what we're going to be talking about as it relates to outcome measures are things like ED visits, admissions, things like that. So that's really what we're going to be talking about related to outcome measures. Now, we mentioned these ED visits and hospital admissions are outcome measures. And again, process measures, just to recenter us on that, process measures would be percent of patients with an asthma control test or a track or the Merck test there too, the attack. And then, or it could be something like a % of patients receiving asthma education. So those are two important distinctions to make as we look at measures. Now, the then question is, how do you actually choose? So all the things that are happening in your practice on a daily basis, all the things we're trying to accomplish all at once, how do we pick the right measure? And this can get kind of tricky. And again, I still have my eye on the chat box over here on the other screen. So if there's questions you have along the way, I am looking as much as I can to see if there's anything in the chat box or if somebody's raising their hand. So it's hard to do via Zoom or Teams, as the case may be, but I'd like to try to make this as interactive as possible. So if you have questions, shout them out. And sorry, we can't be in the same room together today. So as we choose a measure, we need to think about really what's important to us and to our team. And then also, to a certain extent, we got to watch and see what's broken. And so going back to my philosopher Yogi here, you can observe a lot just by watching. So the best thing for you to do as you're trying to choose the right measure to work on is look at your office systems, talk to people, get some feedback about what's working well, what's not working well. And then we're going to talk in the next slide about how to design something to test out to see if it works. But when choosing measures, I think the best thing to do is to really have that interprofessional team, really get everybody's feedback, and have a conversation about what tests of change we can actually make that's going to be effective. And those tests of change are also called interventions. We use test of change and interventions really interchangeably. And so when we're thinking about okay, so now we're going to go back to the example of I want to use the asthma smart form to improve my assessment of asthma control for asthma-related visits, right? So that's our aim, that's our measure. But now what are we going to do? So we've got to start thinking about a couple of things in order to make sure that anything we do from an intervention perspective is actually done properly. So the first question always is it feasible? So can we actually do this? So a lot of times we'll get in a room with a bunch of people and we'll say, okay, we need to build this great tool into the electronic health record. And that is honestly a phenomenal idea. It's really hard to do with high reliability. I can actually build an Epic, our version of Epic. It's really hard, even as a physician builder, to get stuff into Epic, just because of the virtue of the big database that it is. So the first question is always, is it feasible? The second question is it acceptable? And this goes back to the whole oriented method that we use in quality improvement, which is a team-oriented approach. So we have to know that our team is going to buy into this, that they're not going to, feel like this is more of a burden, that this is something that goes opposite in the direction that they want to go in. So really having that team-oriented approach to make sure that it's acceptable, that's I can't emphasize enough how important that is for your success. The second thing is cost. I mean, we're all focused now on cost as part of health reform, but as part of our daily work, anything that we do likely is going to come with a cost, whether it's financial, but there's also other costs that we really should consider. These are just as important. So what resources do we need to actually get this thing done? And how much time is it really going to take for us to go through and complete this intervention and build this intervention? So we're building up an acronym here. And the final letter is going to be, is it effective, right? So we want these interventions to have some face value to them. So they have to be feasible, they have to be acceptable, they have to have reasonable cost. It doesn't mean they're free, it doesn't mean they're cheap, it just has reasonable is up to what the team decides. And then it has to be effective, it has to be able to be measured so we know that it's got some data and oomph behind it. So that's generally speaking how I frame how our team should be thinking about interventions as we move forward. Now, on the next slide, I'm going to go a little bit deeper into the effectiveness portion of it, and this kind of goes back to how we see data. When we look at data, classically in healthcare, we see this. We see a pre-value and a post-value, and there's nothing wrong with this. This is perfectly fine. There are advantages to this and there's disadvantages to this. So this gets us, pre and post, did this work, did it not work? In quality improvement, we look at longitudinal data. So we look at data over time to make sure that we're looking at performance during the context of our busy lives and changing system, whether it be pandemic or cyber attack or staff leaving or other projects coming online. So the longitudinal data is so critical. And so this is one example here. So in this example, so we have data across time over here. This is the x-axis is time. This is our value. This could be percent of asthma control assessment done on this y-axis here. So we see our performance of the system is, around give or take 60%. We'll just say 70%. We make a change, and then the system seems to move down in a direction. That seems like potentially a good intervention, right? But do you think about this data differently, right? So if the data is already on a slope, we make a change, and the data continues to follow that slope, the question to you all is that an effective intervention? Or was the system already heading in that direction before we did that, right? So in other words, if I did this great process, I built this great thing in our electronic health record, I changed somebody's entire job description as my intervention, my change here, this actually is evidence that what I did didn't result in that improvement. So that cost may not be actually worth the effort in that situation. So that's an example of why it's so important to look at the data over time and to map your changes on a longitudinal chart like this, so you can marry the two, your theory of the change and the practicality of actually what happens as a result of that change. In the third example now we're going to talk about is, so again, we've got data up here, around, again, 60, 70% give or take, and you make a change and it gets better, but then it tails off. And this is like such a common problem in everything related to healthcare, right? Where we make a great change, it results in immediate improvement, and then we take our eye off the ball and it starts to filter out and go back to where it was before. So this is a way to emphasize the importance of sustainability. This is a way to emphasize that it's important to have a data collection system that allows you to assess system performance over time to know if you start creeping back up to the old way of doing things. So I put the reference for the paper down here. It's a quick read. It's a good read. It's a great reference if you're trying to frame your projects over time and help look at data. Highly recommend that paper for sure. Now, these are the OneCare measures that we have for this learning collaborative, just as a reminder. And a lot of these are all process measures, which is great. These are the things that we can control. What would be harmful would be to say, we're going to hold you guys accountable to reducing ER rates, right? Because you have some control over it, but not all the control over this. And there's actually going to be a commentary, I believe, coming out that Dr. Plavin and I and somebody from Montefiore wrote about this topic, just that topic of linking process measures, outcome measures, and operating as a team in order to improve outcomes. So keep an eye out for that if we can plug it. So as we go into learning collaboratives and what works, I'm going to take a quick aside in terms of what we did with work here at VCHIP. So if you've heard of VCHIP, you know the work over there. They are a great quality improvement learning collaborative team. They do health service research with Dr. Harder, but we did some work through the CHAMP project in 2015, 2016 that was pretty analogous to what we're doing now. So I'm bringing this up as a way to kind of motivate people to say, like, if we keep doing this, we can drive process improvement and we can drive outcome improvement. And in this particular case, we have a paper in Journal of Asthma. What we did is, just like we're doing right now, we looked at asthma control assessment using a validated tool. We gave asthma action plans as one of our markers, and we really gave a strong focus on prescribing inhaled corticosteroids for children that had asthma. And we used tools to figure out how to develop office strategies to promote those process measures. And if you're interested in any of this, we can reach out to myself or anybody at VCHIP, and we're happy to continue to talk about this. It's something that we're super passionate about, and this is all in the interest of improving care for our patients. As a result of that collaborative, though, so again, this is a proof that we can do this together, that the work that you're doing will lead to improvement. So 7 of the 8 measures that were measured during this CHAMP collaborative were hit. So we documented asthma, in terms of is it moderate or persistent. Asthma control was assessed. We did asthma action plans. We promoted asthma visits. We assessed tobacco use. That's one of the measures for OneCare. We did patient education, always a great intervention. And then we taught people how to use the spacers. So all of them resulted in improvement just by virtue of using the improvement science techniques that I just talked about. And we used longitudinal data that I just mentioned to make sure that the changes resulted in improvement that was significant, but also sustained. And so, again, just proof positive that it can be done. And I just want to take a second now and talk about another specific project that we did here at UVM that to improve asthma control assessment. So again, this is really analogous to some of the process measures that we have now in OneCare. So again, just reinforcing some of the things that can be done and that we did here that you might want to take home to see if they work. So these are actual aims from that project. So the global aim, going back to what we said before, is to promote NHLBI guideline-based care of patients with asthma in order to reduce admissions, ED visits, and prescriptions for oral steroids. Lots rolled into that global aim, and that's fine. That's like all pie in the sky. That's like our big overall arching mission for what we're trying to do. That's totally fine. And then we got specific. We said we're going to specifically, like we said before, increase assessment of asthma control during asthma visits or well child checks using the Asthma Smart Form from 68% to 90% by July 2016. This is an older project that kind of rolled into the CHAMP Collaborative. Now, I've mentioned the Asthma Smart Form a couple of times, and if you don't play an EPIC, you don't know what that is. So I do want to take a second and just kind of articulate what this is. So this is something that we built into the EPIC version here at UVM Health Network about 10 years ago now. It took a long time to get this in. So when we talk about the cost and the feasibility of interventions, this was something we were laser focused on, but it took a long time. There was high cost, high energy. At times it was frustrating just because we couldn't get it to roll out exactly right, not through faults of EPIC, but this is just the virtue of working with an electronic health record. But at the end of the day, incredibly valuable as a tool to promote guideline-based care, but also help us collect research and quality data at the same time. So in this particular case, so to speak, the juice was worth squeezing. So this case was costly, but totally effective in my opinion. So as we look at this Asthma Smart Form, what we see here is the asthma control chart. The asthma control chart's been around for like 30 years, and it's hard for us to remember everything in the chart. And so what we did is we basically took the stuff in the chart and put it as buttons. And so you can go through this and you can click daytime symptoms, nighttime symptoms, interference with neural activity, how much albuterol they're using, and then whether or not they've been on inhaled steroids in the last year. And you can go ahead and click. And after you click, it actually shows up with a little alert here that says, oh, your patient's well controlled, maintain your current treatment, and then get follow-up every 1 to 6 months. And then, hey, by the way, if you're doing well for 3 months, you can actually step down and lower your therapy. So this is a way to get the guidelines to clinicians. I mean, we all go into the business to do the right thing. This is a way to actually help us do the right thing. It also has some other decision support here so that if things are not well controlled, it actually gives a recommendation about stepping up and reevaluate in a couple of weeks. And then the other thing here is, if you can see my mouse, there's little buttons for asthma control here and spirometry interpretation. We put tools into this form so that we can actually give you, if you click on those links, they bring you to a PDF, and they'll show you how to interpret spirometry. They'll give you the chart. It'll actually give you dose equivalents for the different inhaled corticosteroids. So it's all really right there for the providers, again, to do the right thing. When things are out of whack, the alert changes to be red, so it's much more in your face. But again, this is an intervention designed to help us do the right thing. As we all want to do, we always want to do the right thing. We're compassionate, caring people. We're intelligent. We just need the systems to help us support our work and to make it a little bit easier on our shoulders. I'm happy to answer questions about that at the end if we need to, but what I wanted to do was talk about, so it wasn't all about that smart form. And I, to be honest with you, I made a really goofy mistake when I was younger, because when we built that, I was like, this is awesome. This is going to be like New England Journal of Medicine. I'm going to be wicked famous. I'm going to get a nice car, because I thought it was like the greatest thing. I said, here it is, go. The problem is we didn't use it. And we didn't use it because I didn't roll it out the right way. I made a huge mistake just assuming that people were just going to use it because it was there. That's not effective. So that doesn't go after the psychology of change. It doesn't go after the spirit of teamwork. So I made mistakes about how we rolled that out, and I learned from them. And here are the things that I learned. So Dr. Ward just asked a question about the parameters as a Word document or PDF. It actually comes out as a PDF, so you can adapt it to other EMRs. And I'm happy to share as much as I can with anybody, just because that's what we do, right? We're all one big team in Vermont. So I want to just talk about some of the mistakes that we made and how I learned from those mistakes and how we plan interventions to lead to improvement in this particular case. So it wasn't just about telling people to do it. So the first couple of interventions you can see here is we did some training for the staff that were directly involved in the screening process. We then implemented clinic huddles to make sure that people were grouped together to plan out what the activities were. And then we had a provider meeting to train the providers about doing this and provide another double check so if the LNAs or the nurses didn't complete the screening, then the providers knew to double check. So there was redundancy in the system right there, right? So we kind of thought about like what the processes were and how to engineer this in, so to speak. And then we gave people their data. Again, I've said a couple times, we're data driven. That's who we are. We should embrace that. And we should embrace it as a motivational tool as well. So I gave people their data, and this was done in a supportive way. This was not me emailing the entire group saying, you only did 30%, you're a bad person, how do you sleep at night? It wasn't that kind of thing. That's not, well, one, I'm a pediatrician, that's not how we roll. But the second thing is that's never a good way to motivate your team. So our dashboarding intervention there was me sending a group email out to everybody with blinded numbers on them. So nobody knew, there were 20 numbers on the chart, each with performance. And in order, if you wanted to know which number you were, you had to email me to get your number. And that was a way for people to engage. And if they emailed me to get their number to figure out who they were, then that's when I said, hey, great job, you did 80%. What's working for you? Like, why are you so high on the performance here? Why are you an outlier? How can we help get this out to other people? And if somebody was on the other end of like they did it 10% of the time, I said, okay, so what's not working? What's broken about the system? What did I not remember to do for you to make this easy for you? And how can I make this better? And so through that, it was a way to engage, but it was a way to reinforce at the same time. And that's actually what led to the improvement. So after that, we actually got up to our goal, which is 90%, and it was holding there for a long, long, long period of time. So again, this is a way to say, when you're thinking about interventions and changing your system, really think about the process you really want to build in and plan your interventions in a way that leads to that outcome. Throwing things at people right now is really challenging. There's a lot of stress going on out there. So really be thoughtful about how you're planning interventions, how you're collecting feedback, and make sure that the feedback is as much as you can, make it non-punitive. This is a nice project because it's not immediate harm. I think if you're talking about central line infections or, CAUTIs, urinary tract infections related to urinary catheters, that's a different project and that's a different, feedback loop. But this is a project where we're trying to get on the same page and build teamwork. So a little bit of a lower stress environment. Now this is a busy slide. What I want to do is we looked at this chart here on steroids. Okay, so this is your weekly percentage of asthma control assessment here, and then this is your mean performance on the red line. These are all the interventions, and what we also do in this particular graph, this is a control chart. So there are statistical method to what we do in an improvement. So I can tell you with 99.7% certainty that your data is going to fall on a certain percentage by using a chart like this, because the red dotted line is your upper limit and your red dotted line on the bottom is your lower confidence limit. So that's 3 standard deviations above and below that mean in the middle there. And so what I want to highlight on this particular slide is that when you have team members leave, when your epic changes, when you focus on other projects, your performance, your percent of asthma control assessment will go down. And that's just life. That's life in healthcare these days, where we have a lot of changing staff, changing electronic health records, focus on other projects, and hopefully just no more pandemics. So there are unintended consequences to other changes. There's unintended consequences to adding more projects to people's roster of things that they have to do. There's unintended consequences to changing how your EHR looks. And those are called balancing measures. Those are the harmful things that can happen by doing quality improvement work. And it's really important to not only think about, outcomes and process measures, but also about the balancing measures, because if the balancing measures are high, they're going to kill your improvement project. And so as you start changing things, start thinking about what harm could I possibly do by doing this intervention, right? And that's going to actually help put us all on a direction of improvement and success. So that just a quick plug to think holistically about what we're changing and the implications. I'm going to shift gears in the final 20 minutes or less and talk about emergency department visits. I think if we were to say, what do we want to do for our kids and families? We would love to be able to reduce ED visits, right? ED visits are costly. They mean that our asthma control is not good. It means that the child may need to be admitted, and the parent may have to take off work. ED visits are incredibly wasteful, incredibly stressful, and they also result in, they kind of signify a need for improvement. And so we're going to talk now in the next several slides about a project that we did to decrease ED visits. And in this, I'm going to reemphasize some interventions that are evidence-based on how to drop ED visits in your practice. And these kind of relate to the asthma process measures that we have here for OneCare. And so what I'm going to do is walk everybody through what's called a key driver diagram. Now, it may look daunting at first, so we're going to walk through it step by step. This is one of my favorite things to use in quality improvement, because it's kind of a roadmap to improvement. If you have a good driver diagram, it'll set you on the road for success in 99% of the cases. So here's our friendly and familiar global aim, right? So we want to improve care for children with asthma by understanding the systems issues and creating partnerships between healthcare providers, improvement partners, health plans, and public health agencies. So that's our global aim of trying to reduce ED visits. So we're going to put that up in the left-hand corner. The next thing here, we have smart aim. We always have smart aim. So we're going to specifically reduce the number of ED visits for 100 kids, 100 child year for children managed for persistent asthma from A to B. So whatever numbers our baseline performance is and whatever number our target performance is by New Year's Eve of this year. Okay, that's our smart aim. So we're going to do that, and we're going to put that over here. Now, there are a lot of reasons why kids go to the ED. And we just did a grand rounds about this a couple of weeks ago. So a lot of these slides are borrowed from that grand rounds and in the work that we did with Dr. Harder and Christine Pellegrino from VCHIP. The work that we did at VCHIP actually allowed us to identify a lot of different factors of why children go to the emergency department. There's a ton of them out there. And if I just even mention why children go to the emergency department for asthma, your brain's already probably spinning about all the different reasons. Is it smoke exposure? Is it a cold? Is it didn't take the medication? Is it not doing it properly? There's 1,000 reasons, right? So but you can't address all of them. You can't hit the 5-run home run, right? Not to be cheesy, but that's what we talked about at the beginning. So we've got to figure out a way to bucket these in a more manageable way. So we've got to put them in terms of key drivers. So we're going to group them into 3 things. So we're going to make sure that our care is evidence-based. We're going to make sure that we're meeting our patients' and families' needs. And we're going to make sure that the healthcare system is actually supporting us and our patients and families to do the work that needs to be done. Okay, so that's the general framework of all the 1,000 things that we're going to think about when we think about kids going to the ED. We're going to put them in those 3 clear buckets. Okay. Now, the first one here is we're going to look at what are called secondary drivers. So these are the 2 specific things related to care as being evidence-based. So two examples that I have here. One is that primary care docs and providers deliver evidence-based care according to the guidelines, right? So that's on me. Did I not do what I was supposed to do as a primary care provider or a subspecialist of recognizing the child was not well controlled and increasing medicines when I was supposed to? So that's something that's a factor that falls under care as evidence-based. The other one is the data systems provide feedback to healthcare providers regarding performance. So there's actually been studies where they will give providers feedback about whether or not they followed the guidelines, especially if kids have gone to the emergency department. They've actually even given providers feedback when kids show up to an emergency department and say, hey, did you know that Timmy came into the ER last night and needed steroids and needed to be admitted, that kind of thing. That feedback loop allows the clinician to really interrogate what happened and identify any of those factors that led to that ER visit. So those two things, and also collaboratives like this have been proven, like we just showed, to improve adherence to the guidelines. And I'm actually going to show you that if you adhere to those process measures and the guidelines, they can actually reduce ER visits. And so that first bucket of work is all about delivering evidence-based care, living in a connected system where you know what's happening with your patients, and where we're always driven to deliver ideal care. Now, in the second bucket, so to speak, there is meeting our patients' and families' needs. Now, at the center of everything that we do are patients and families, and at the center of the driver diagram are patients and families. And so to that end, we need to recognize the importance of social determinants of health. Vermont has done a really outstanding job. OneCare has done an outstanding job at recognizing the importance of social determinants of health, especially food insecurity, and providing care coordination services to patients and families. And there's actually studies that say if you deliver those care coordination services, you can actually drop ED rates. And so that's a clear need to recognize our case managers and care coordinators. And so if there's any care coordinators on the call today, thank you very much for everything that you do. Our patients and families need you, and we need you, and we definitely can't say thank you enough. But that's a way to also advocate for resources at your practice level to make sure that we're coordinating care as best we can for our patients and families. The other thing rolled into the patient and family needs are met is that patients and families need to understand the importance of how to manage the acute episodes, how to manage the day-to-day activities of having asthma. And increasing asthma education can drop ED rates, as shown in that paper there too. And so it just really emphasizes the importance of asthma education. And we're going to go to that in a second. Like I mentioned before, care coordination and social determinants of health. In this particular paper that I mentioned, they looked at asthma education, asthma action plans, its assessment of symptom control, and they also integrated with schools. And I think this is a huge opportunity for us in Vermont. We have a highly activated and engaged school nurse network, and that's as it relates to pediatrics, that's a huge opportunity for us to engage clinicians where kids spend a large majority of their time, and it's really a nice partnership to have. So something for future thought for sure. The other thing about asthma education, so Karen Casper coordinated an enormous effort to put together a great set of asthma videos that are actually we're trying to roll this out now. So these are going to be publicly available so that if you're trying to, if you pick off that one measure of improving asthma education, we're hoping to be able to bring these resources to you. And there's videos on what is asthma for patients and families that are newly diagnosed with asthma. There's videos on asthma spacer use, like is shown on the video on the right with Melissa Barron. She actually gave one of the talks at the start of the collaborative. And then there's other great talks by Sarah Cosgrove here too. So keep an eye on these, and we really want to get these out to people to make it easier for us to achieve that goal of improving asthma education in your practices and through the visits. And again, thanks to Karen Casper for putting all that together. The last bucket here that we're going to talk about are the healthcare system supports. And so we're here today as part of the One Care Collaborative. It's great that One Care is putting this on because it's how the healthcare system should be supporting improvement in practices in the community. Because there's evidence that doing this actually works. It works to drop ED rates. It works to improve our collective knowledge of quality improvement and population health. It works to promote teamwork, and it works for patients and families to get great care. And so these things actually work. There's evidence to this. And we're going to talk in the next couple slides about some evidence that we have recently that collaboratives actually do drop ER rates. As a quick aside, when we talk about healthcare quality measures, the federal government has something called the Agency for Healthcare Research and Quality. So they decide, like, these are where the quality measures come down from on high. There are some related measures for pediatrics in the Pediatric Quality Measures Program. These are really good measures that are specific to pediatrics. And one of them that we tested here in Vermont at VCHIP, and this is work that was done by Dr. Harder and Dr. Shaw over at VCHIP, was looking at ED rates for children with asthma and how to decrease them. Eventually, once these measures get approved, they actually go to the National Quality Forum. There was a lot of work that went into this. It was an interstate collaborative from providers from New York, from San Francisco, and here in Vermont. And we looked at, is this a good measure and is it usable? This is a deep in the weeds slide, but this is the measure that's going to go to NQF for approval. And it really is a good measure, actually. It's the number of ED visits per 100 child years. So at first you might be going, well, wait a minute, kids don't live to 100. Well, I would argue that kids actually do live to 100 because adults are just big kids, so don't worry about that piece. Another way of thinking about the measure is the number of ER visits for 100 children with asthma in 1 year. So that's probably like a simpler way. That's how I think about it. So the number of ED visits among 100 kids that had asthma during that 1 year. That's going to be the measure. So we tested this out in San Francisco and in Vermont. Dr. Harder did a ton of work looking at data from a lot of different states, a lot of different ways to look at the data in terms of day of the week, area, things like that. And what we basically found when we applied this to the practices that participated in CHAMP before, these are the CHAMP practices down here in the orange line. If you were a CHAMP practice, your overall rate in that measure of children that went to the ED for asthma dropped after you participated in that quality improvement collaborative. And if you didn't participate in the CHAMP collaborative, the learning collaborative, then your rate of children that went to the ED stayed high or higher, right? This is an emphasis, and this is the why. This is why we're here today. This is why we're talking about this, because all the work that you're doing can lead to better outcomes. It can lead to less kids in emergency departments. It can lead to less parents having to take off time from work. It can mean less costs in the healthcare system. This is the why. This can work. And if you want to read more about it, the paper has been published in Pediatrics, and it's there if anybody has questions. Certainly reach out to myself or anybody at VCHIP, and we're happy to discuss further. But this is, again, just emphasis that the work that you're doing as a result of this collaborative can lead to significant improvement. So I want to leave enough time for questions. I know we blasted through a lot of stuff there. I want to, as much as we can have in a remote conversation, want to have some time for questions. But in summary, I hope that we at least touched on the opportunity for improvement science to be used to improve health outcomes, right? That's the work that was done through CHAMP. It's the work that you're doing right now. We can do this. We can improve health outcomes by using improvement science. The second thing I wanted to talk about today, and hopefully we got across, was that understanding your current system is so important to planning interventions. So don't be naive like I did at the beginning when I was rolling out the Asthma Smart Form and just put something in place and expect people to follow it. Get your team together, nursing staff, medical assistants, LNAs, any provider, front desk staff, get a patient and family advisor on, right? That's ultimate quality improvement if you have a patient and family advisor, so you can co-collaborate and co-develop interventions and system improvements. Get that team together, really think holistically about your system and plan out what you want the thing to look like. And that's actually how you start planning your interventions as you start your improvement work. And again, we emphasize the point of teamwork. I can't emphasize that enough. That's why I love quality improvement so much, is because it's all about the team. And again, patient and family are at the center of that team. And to carry the teamwork analogy one step further, QI coaching is so important to making sure that we do this with speed, efficiency, and with fun. My other philosophers that I look to commonly are Ben and Jerry, and they've got a bumper sticker that says, "If it's not fun, why do it?" That applies to a lot of things in life. I think it can apply to quality improvement. We should have fun as we improve our systems. It's fun to see patients and families. I'm actually in the middle of clinic today, and I love all the quality improvement work I do. I love the research that I do, but hands down, the best day of my week is seeing my patients. And so I have a ton of fun seeing patients, but I also have a ton of fun doing quality improvement. And I hope you guys also have fun as you engage in this work. So that's it for me. I have some acknowledgments here. Certainly, Dr. Shaw, Dr. Harder, and Chris Pellegrino from BCHIP, need to thank them and everybody else listed on the slide that participated in this teamwork. I'm happy to answer any questions or take any comments now. And we left about 12 minutes for questions. Is that okay, Dr. Ward?
That's perfect. Keith, could I just start off in terms of the videos? Is there a link, or are they in process of completion, or where do we go to get them?
That's a great question. So we're working on, Karen may be able to offer more details on where to get those right now. We're trying to figure out a great platform to deliver them. And this actually may be a great opportunity for improvement. So if anybody has any ideas, or if they've got special skills in web analytics, or thoughts on how to engage patients and families or providers more in this project, or if they have a teenager that's wicked good at using technology, certainly reach out and we can certainly discuss that. For right now, we're trying to figure out the best platform to get these for people. Right now they're web-based.
Right. So, I mean, I would just throw out that, the Vermont Health Learn, which is a collaborative between the health department and OneCare and Blue Cross, I believe, and that platform, can be a destination for this kind of content, although there's probably no dearth of places to, once the videos are available,
Okay.
where to put them.
I like that. I'll reach out to Karen and see what we can do about engaging in that platform.
A note, we've been piloting that through a small little window asthma module on that platform, and it seems to be working well. All the videos are completed. They're also being piloted through UVM Medical Center's communication platform as possible use as links. The trick and challenge is to try to, as Dr. Keith was mentioning, to be able to see what the effectiveness of those are for patient care. And so really not only having them available for patient care, but also being able to find a way that we could track value added or patient outcome improvements, or any of the other process measures. So how do we link those to, seeing how well those help serve our patients, Vermonters.
Yeah. I like the idea of YouTube. We did a series of these videos when I was a fellow down at UNC, and they were on YouTube. I think that's a very useful platform as well. So I like that feedback.
Keith, while we're waiting for other folks to ask questions or put them in the chat, we heard from Dr. Balachandran last month about kind of I'll just say borderline efficacy of action plans for COPD.
Yeah.
I know that your asthma smart forms result in the creation of a asthma action plan. Can you quote us the literature in asthma for the efficacy of the action plans?
Yeah, I think that's a great question, and I was going to go there in the slide. There's slides down deeper in the deck that go on. I'll just talk. The data basically, in my interpretation of the data, is that asthma action plans alone are not as effective as the process of giving somebody an asthma action plan. So in other words, just checking off a box like, yeah, I gave you this sheet of paper and it's got a bunch of stuff written on it and you should just do this. That's not effective. I think when we start adding visual cues, like in the green section, here's a picture of what Flovent looks like, that's helpful. Here's a picture of what albuterol looks like for your rescue medicine, that's helpful. Here's what a spacer looks like, that's helpful. I think those, and it's also how you engage patients and families in that education. It's how, it's the proper way of educating, of even doing something like a read back could be more impactful than opposed to just telling somebody what to do. Same thing applies to smoking cessation, right? I mean, telling people, and you know this, over and over and over again doesn't help, but it's how you engage patients and families in this. That's the magic sauce that leads to the improvement. So it's not just checking the box like, yep, I gave it to them. It's what format is it in? Is it readable? Is it understandable? And does it go the distance? And does it have visual cues? And that was actually published in Pediatrics a few years ago about if you use visual cues, it can actually help improve uptake of asthma education. That's a great question.
So Keith, I'm looking at a comment from Amy Janacek early on in your talk about trying Zoom inhaler teaching visits,
Yeah.
and kind of marginal uptake from people willing to engage in that. Do you have any comments on spacer education in general, methods and efficacy?
Yeah, I really, that's a great, I must have missed that earlier. I'm sorry if I did. I love that idea of trying to Zoom inhaler teaching visits. I mean, it's the one thing, I mean, we have to look at the bright side. The one good thing about COVID is that it allowed us to turn on telemedicine a lot more quickly than I think we were on track to. And so using Zoom or other platforms like that to engage patients in education is awesome. I love the idea of using Zoom for inhaler visits. We've had a hard time engaging on that platform as well. I think part of the reason it might be related to finding the time for patients and families and syncing up with our time and their time. The other thing that I've actually had a lot of success with, at least in the couple of pilots that I've done, is I'm starting these what are called collaborative visits. And so I'm a peds pulmonologist, and so if somebody's being seen at a visit, primary care office in like Porter or CVMC or anywhere in New York, actually I've done them in New York too. The child and the family are in that outside office, and I will Zoom in to do the home visit, but at the same time, we try to capture spacer education at that same time. So I love the idea. I agree. I think it's hard to implement at this point just because of the time requirements and syncing that up. But I do think it's another opportunity to think a little bit differently about the healthcare system, and maybe it's asking us, a specialist, if we can, to kind of Zoom in and take advantage of that time that we already have with the patients and families. This is even more important in the context of COVID because we saw visits kind of drop off. And so that meant that every visit that we had with patients and families was so critical to make sure that we were efficient and achieved all of our goals.
So Keith, Ellen Talbert just put a question in the chat.
Okay.
At 12:54.
Yeah. So yeah, are you any studies that show the rate of improvement for patients that are given an asthma action plan from their provider versus from a nurse or MA? I don't know of any studies around the difference between, parsing it out that way, provider versus nurse or MA. I think it's, again, going back to what I said before, I think it's probably in the how of how the education is delivered, how patients and families are engaged. But that's a good question. I'll look into that. And Ellen, if I find anything, I'll try to find your email and get back to you. I see another question. AHRQ seems to use a mix of Brightcove and YouTube to provide resources to professionals. Brightcove was new to me, but I've liked it so far as a Windows Chrome user, and it's intentionally focused on business and professional needs. That's a, I like that. I'm going to write that down. And then for those of us not on Epic, is there another solution for action plans? Type of visual cues that make them more effective? Yeah, so that's a great question. We actually started messing around, believe it or not. We have Epic in that smart form I just showed you. We were actually messing around with a Word document a couple years ago that actually had stock photos of Flovent and Advair and Symbicort and all the other inhalers. And we were, for a while, just using a Word document. So it's a little more labor intensive to do that work, but it actually can be effective if it's possible in your office. I don't know of any other like web-based tools that could do that, but it would be interesting to see if they were out there. And let me just say, I guess we were using that the Word document as a like a test, as a PDSA cycle of, is it more effective? Is it doable for us to give somebody that information using using visual cues? Does that add value to the asthma action plan as an education tool?
Keith, I know this isn't really necessarily the topic of the day, but I think you're in an enviable position having an asthma educator to work with.
Yeah.
In the last couple of minutes, can you just kind of map out, how you use that person and how smaller practices might, I don't know, replicate at least part of getting somebody geared up to be a asthma expert?
Yeah, that's a good point. We take our asthma nurse educators and asthma educators for granted, for sure. It's an incredibly a challenging course to take. The certification's not nothing. So there's a lot of investment that goes into it. And then it's the how they do things that's also really important. It's again, goes back to the engaging patients and families to make sure they're conveying the information the right way. I think one thing we've been talking about is there a way to use like remote, especially in the context of COVID and now more telemedicine, is there a way to use asthma educators in partnership with practices, kind of going off of the question that was asked before? I don't think we've got a great plan for that at this point, but I think that's something we could definitely explore at some point. If you don't have the resources to have an asthma nurse educator, an asthma educator in your office, then I think that there are opportunities to provide other education and really think about how to deliver the information to patients and families in an effective way. And so maybe hopefully these videos will help. And I think the other thing is hopefully, reaching out to our team to say, okay, what asthma education materials do you have? What can you let us borrow or steal to help support your local teams? I think we're all happy to do that. I mean, it's patient education, so it's ubiquitous, and we should be ready to share that stuff at any time. So if you are wanting to improve the collective knowledge of your team, reach out to us, and we'll try to share as much as we can for patient education materials, and be a resource if you're having questions about how to do certain things from an education perspective or from a resource perspective.
Well, I think we're at time. I just want to express our great thanks for your terrific presentation today. When you see beautiful graphs documenting hours and hours of, quality improvement work, I mean, it's very impressive to see that. If you want to hang around, the collaborative folks are going to meet between 1 and 1:30, but I understand that your notes probably call. For the people in the collaborative, please stay on the line. For those that were here for CME mainly, you can take your QR code photograph or copy down the link to the UVM CME website. And I think I'm going to give over to Adrian to run the next half hour. Thanks all for being here.
Thanks, everybody. Be well.